Hi, I'm Julie Lubinsky. I am the Associate Director of Digital for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to our special webinar called Polypharmacy, Are You at Risk? And it's hosted by Jay Gupta today. He's an award-winning pharmacist and medication therapy management specialist, and he's going to outline the concerns associated with taking multiple medications. So you'll have time as well to ask questions using the chat box, or when you're ready, you can hit *1 on your phone and you can be logged in on the audio call. So now I'm going to send it over to Jay. Hi, Jay.
Julie, thank you so much for the introduction. Hello, everybody. So today we're going to talk about polypharmacy. I'll give a definition of polypharmacy. We'll discuss the risks and maybe some benefits or the problems associated with polypharmacy. And the biggest piece is how do we really minimize if there's any risk with polypharmacy. I would like to start with a disclaimer here that I'll use some data and the pharmacist kind of lingo in the beginning of the presentation. So you are welcome to tune that part out, but some of you might find it interesting how technically polypharmacy can be really an important thing to know about. So let's start the presentation with two poll questions. I'm going to put the first question up. How many pharmacies do you get your medications from? So in the past, most people used to go to only one pharmacy, but in present time, some people use mail order pharmacy. Sometimes you have to shop for medication. You might get some samples from the doctor's office. So in past 1 year, how many pharmacies did you use? So the poll is up there. So please pick your choice. Include hospital pharmacy if you had to use a hospital, maybe emergency room. Some people buy their medications from the internet, so it might be coming from outside America. So a few more seconds and I'm going to all right, so I'm going to close the poll. I don't think I have a message from everybody here, but anyway, respecting the time, I'm going to close the poll. So we had half the people using only one pharmacy, which I think is awesome, and half the people who participated in the poll used 2 or 3 pharmacies. Actually, this number is changing now, so I have a few more polls here. All right, so thank you for participating. I just wanted to get some idea to make it relevant for all of us. The second poll I have is, how many medications do you take at the current time? So total number of medications, which might include prescriptions, over-the-counter products, supplements, natural products. If you take a medication once in a while, if needed, please count that as 1. If you take a medicine 4 times a day, please count it as only 1. Some people take an injection or a pill once a week or once a month. That will be another count. All right, so I'll close the poll. Let's see what we got. All right, so about half of you take only 0 to 4. Another half takes 5 or more medications. So thank you for participating. And so this lays the groundwork for our presentation. So what is polypharmacy? So patients, when you use multiple pharmacies, is not the real definition of polypharmacy. This is what many of my colleagues, even pharmacists, think. The technical answer is when somebody takes 4 or more medications a day. And excessive polypharmacy is usage of 9 or more medications. So there's no consensus in the literature on what is the definition of this concept of polypharmacy and excessive polypharmacy, but World Health Organization, the WHO, they define polypharmacy as administration of many drugs at the same time. And excessive polypharmacy is defined as the concomitant use of 9 or more medicines taken regularly or as needed. However, if you're using multiple pharmacies, that also compounds the risk factor for both of the problems. So in spinal cord injury and polypharmacy, this was a research published in the Journal of Spinal Cord Medicine last year. What they found was spinal cord injuries are associated with higher rates of polypharmacy. And there are multiple risk factors involved, but high-risk medications like painkillers, anti-seizure medications, antidepressants, muscle relaxants. So these medicines cause higher risk, and some people use multiple medications within each class. For example, somebody might be taking Tylenol, ibuprofen, along with an opioid to reduce their pain level. So as we keep adding more and more medications, the potential for adverse drug reaction, that ADR stands for adverse drug reactions, so that incidence increases. And that leads to problems with rehab goals or the quality of life. So this was a research published a couple of years back, I think year 2015, in JAMA, which is Journal of American Medical Association. And what they found was polypharmacy had increased 83%, excuse me, 83% rise in polypharmacy between year 1999 and 2012. And this is another slide from FDA this is from NIH website. Polypharmacy research has clearly established a strong relationship between polypharmacy and negative clinical consequences. So this study was presented, this article was based on study with older adults. So let's look at some of the problems associated with polypharmacy. The first thing is the confusing daily medication regimens. So if you take multiple medications a day, some of them you might be taking first thing in the morning. For example, thyroid medication is supposed to be taken first thing in the morning, at least half an hour before breakfast. But you might need some medication you're taking with breakfast, lunchtime, dinner time, supper time, at bedtime. So that can be very confusing. So what I recommend is using a pill organizer. Depending on how many medications you take, they come in all different sizes. So they help you figuring out the right timing so there's less confusion. The second biggest problem is the drug interactions. So the drug interactions do happen when you take two medications together. Any two medications may or may not interact. So in earlier times when we used to have a lot of infectious diseases, the doctors will prescribe an antibiotic with a painkiller or maybe something like Tylenol to reduce the fever. So these two medications can be very independent without interacting or hurting or antagonizing or potentiation. But nowadays there's so many medications we have which create synergy, potentiation, or antagonism. So I apologize, this is a little bit of pharmacist lingo here. But the drug synergy would mean that if you take two medications in the same category, they will potentiate the effect of each other. For example, if you are taking a sleep medication so that you can fall asleep or stay asleep, and you take an allergy medication, something like diphenhydramine, also known as Benadryl, so they both will increase the effect of each other. Another big example is anticoagulants. So somebody needs a blood thinner, and you take an anticoagulant, and you're also taking aspirin, which is normally recommended for pain as well as for cardiac health, so that can cause a person to bleed excessively. So this can be a very potential problem which most pharmacists, when they are filling the prescriptions, they catch this kind of drug interactions. But if you're using something over the counter, that's why I picked these two examples for you. So if you're using an allergy medication over the counter, or you're using aspirin over the counter, your pharmacist and the doctor may not know and can lead to a problem. The second issue is potentiation. So that happens with two unrelated drugs, which when you take, either one can increase the effect of the other or both of them. So it's not a drug example, but if you are taking a statin, which is a cholesterol medication, so anything like atorvastatin, simvastatin, so those medications are not recommended with grapefruits or grapefruit juices. So when you take grapefruits and you take a statin, both at the same time are competing for the same enzymes in the liver, thereby they increase the effect of the statin. So it may not work very well, but it can cause extra side effects. Another big problem which happens is with a pain medication called acetaminophen. So commonly we call it, the brand name is called Tylenol, but it is also known as APAP, APAP, or it's, in many countries we call it as paracetamol. So acetaminophen, APAP, Tylenol, paracetamol, all these names are indicating the same medicine. And this medicine is there in many, many different products. It could be, in multiple over-the-counter products as well as prescription medications. So it's a very safe medication usually, but tens of thousands of Americans are hospitalized every year because of interacting with alcohol. So if you're drinking alcohol and you're taking this medication, particularly multiple products containing acetaminophen, that can cause huge liver problems and hospitalization, and several hundred people die every year in America because of this. So we have to watch for the potentiation of a drug with another drug as well as some of the food items. Antagonism. So when you take two drugs and they reduce the effect of each other, it might be reduced effect of one medicine or both the medicines. So I'll give you a couple of examples so that it makes a little sense for you. There is a medication called naloxone. We use it for reversing an opioid or heroin overdose. The brand name, very popular brand name, is Narcan. So when you give naloxone and you're taking a pain medication like hydrocodone, oxycodone, the effect will be blocked because of that medicine. Another very common example is HIV medication. So most of the antiviral medications, they need acidic pH in the stomach. So we need the acid in the stomach so they get absorbed into the bloodstream. If you're taking a PPI, an antacid, a proton pump inhibitor, I'll give you a couple of examples. So it could be just Tums, it could be ranitidine, cimetidine, or the PPIs are omeprazole, also known as Prilosec, Nexium, pantoprazole. So if you take any of these medications, the HIV medication may not work because it's going into the body, but it's not being absorbed into the bloodstream where it works. So these interactions are very, very common, and pharmacists are really experts in catching those interactions. Most providers, most prescribers also look at those interactions before the prescriptions go out of their electronic medical record system, but some interactions just escape everybody. So I want everybody who's listening to this presentation to be aware of how the drugs can be synergistic with each other, they can potentiate, or they can antagonize. And these interactions also affect the half-life of the medicine. The half-life is the life of the medicine in the body. So in about whatever time frame that is, it reduces the blood level of that medicine to half. So for example, I'll give an example of zolpidem, also known as Ambien. So it's a sleep medication. So it lasts about 2.5 hours in the body. In about 2.5 hours, it will be reduced to half, whatever quantity you take. Then it takes about 4 or 5 half-lives for the drug to be completely eliminated from the body. So if the half-life is 2.5 hours and it takes 4 or 5 half-lives to be eliminated from the body, that means the drug is going to stay in the system for about 10 to 12 hours. Okay? But if you're adding another medicine on top of it or multiple medications on top of it, the half-life will be affected. So that will affect the dosage and the frequency of the medicine. So to sum it up, polypharmacy is a chemical cocktail that we add into a chemical soup which is inside our human body. The human body is just a chemical soup, and we are adding more chemicals from top, and it just creates more chemical reactions for us. So they have all these potential side effects with each medicine. They can be potentiated and impact the quality of life of a person. Sometimes these interactions make the diagnosis of a disease also very challenging. So for example, if you take a medicine which causes dizziness or some of the hallucinations or sleepiness, tiredness, fatigue, it might cause nausea and vomiting, it might cause constipation, and you go to the doctor might diagnose it as a different disease, so that diagnosis goes into your chart and you get more medicine. So what we call it is called prescribing cascade. So that means you start with one medicine, you have a side effect, you get another medicine because of that, and that medicine causes another side effect. So you keep adding more medicines into your daily routine because you're trying to mitigate the side effect of the original medicine. So this is another thing you need to watch out for. So all these things can lead to more of the adverse drug reactions, and these adverse drug reactions can have significant consequences. So this slide I pulled out from the FDA website. Right now in America, ADRs, the adverse drug reactions, have become the fourth leading cause of death. I'll repeat that. Fourth leading cause of death in America is the drugs, the adverse drug reactions caused by the drugs. So about 100,000 people in America die because of adverse drug reactions in America. So this is another slide from the FDA website. So about 1 million people get seriously injured or die because of ADRs. And this has been climbing up. If you look at the chart from 2006 onwards, the number of people who are seriously injured or have died because of the medication is constantly rising because we are prescribing more medications, people are using more medications. And another very obvious issue with polypharmacy is the cost of the medication. So medication costs have been going up. You might pay only a small amount of money, like $1 or $2, maybe $5 or $10 as your copay, but your insurance company might be paying a bigger amount. And if insurance company is paying a bigger amount, overall it adds to the healthcare cost, and that's why our premiums keep going up. Another issue we know, the insurance landscape can be very confusing, very frustrating, and changes all the time. So looking at the copays, the deductibles, the donut holes for people who are on Medicare, out-of-pocket costs, and then we going in and out of the network. So that can be very challenging. And sometimes when you are stabilized on a medication, the drug formulary changes, so insurance companies or these pharmacy benefit management companies, they insist on changing the medicine as well. So that's where you really, it can be very challenging if you're on multiple medications. So now I'm going to switch gears and we'll talk about some strategies, actually 6 strategies, what can we really do about this issue called polypharmacy. Checking if there's any question. Please feel free to type any questions you have. That's in your chat box. Thank you. So the first 2 strategies are very simple. Everybody has been talking about it. Know your pharmacist and know your medication. So let's talk about know your pharmacist. So pharmacists go to school just to learn about the medicines. Pharmacists may not know much about a disease condition, but we are medication experts. So if you have any question, any time, please ask the pharmacist. If you're using multiple pharmacies, you might want to talk to at least one of the pharmacists so that they can oversee all the medications. If you're using multiple pharmacies, another thought is you can give your complete med list to all your pharmacists so they can check the interactions as well. Building a relationship with one pharmacist. You can do it in person or over phone. When you pick up a prescription, sometimes pharmacists would like to talk to you. Most people want to listen to it, but some people are in so much hurry they don't want to accept the counseling. Please take advantage of that situation. Let the pharmacist counsel you. If you have any questions, any doubts, ask questions. Because if you don't ask the questions, you're probably not doing justice to yourself. If sometimes, many times actually, in the retail chains, people are really busy. The pharmacist is very busy, and I've seen many patients will tell me, oh, I don't want to really bother you. When somebody asks a pharmacist a question, it's never a bother. It's actually we get excited because then we are doing a really good job to help a patient optimizing the drug regimen. So please ask the question, and if the time is not right and you have too many questions, then ask the pharmacist what is the best time to call or come in. This I think everybody can use. The next point is how can I save money on my prescription medications? So there are 340B nonprofit pharmacies in almost every community. We call them federally qualified health centers. They use a sliding scale. So people, when they don't have insurance or they have huge deductibles, huge copays, those pharmacies can come in very handy. So you can find information about those pharmacies. I can send you information if you have specific questions within your community where to find that kind of pharmacy. Generics. So if you take generic medication and your copay is, say, $10, you might think like, okay, it's normal. This is my insurance company. That's the copay. It's okay to pay that amount of money, but unless you ask the pharmacist what is the price without insurance, they're not going to tell you that it's cheaper without insurance. Okay? So it's an insurance companies insist. It's a legal requirement that pharmacists will not volunteer to tell you that you can buy it cheaper if I don't use your insurance. So what I recommend is patients, the people who are using the medication, they ask the pharmacist. So for example, your copay might be $10, but the cash price might be only $4 or $5. So please ask that question. The brand name medications, now they are very expensive. The copays are high. So asking for a generic alternate. So for every brand name medication, there's a generic alternate available. So checking on that. Some people, in my practice, I have found, feel the brand name medications are actually better than generics. Now, whatever the influence is, it is because of media, all the marketing we do in the pharmaceutical industry. That might be the influence, but I wanted to give you a tip here. The generic medications have been around for at least 15 or 20 years. We have a lot of experience with them. The whole healthcare industry has experience with them. If there is a side effect with the medicine, what is good about it, what is not so good about it, everything is documented. We know a lot about the drug interactions also. That's about the generic medications. A new medication, which is still in a brand name only, they not only cost a lot of money, we do not know everything about that medicine. So just wanted to give you that idea that generics are not really bad medications. We have a lot of experience with those. If you have to take a brand name medicine, you can ask for a voucher or a coupon. You can find those on the manufacturer websites because manufacturer also want you to use that brand name medicine, so they sometimes give you those coupons to reduce your copays. Now, you cannot use those vouchers or coupons for every insurance, so depending on the insurance and depending on the state you live in, you may or may not be able to use those coupons. And we're going to switch gears to the second strategy now. Know your medicines. So if you know your medicines by their colors and the shape and sizes, it's probably not the best idea. Please learn about those medicines. You might take them for the rest of your life. You might take them only for a few days. Either way, understanding what those medicines are, what are they doing in your body, and how do they work is very important for you to know. So the first point I wanted to make here was that buying your medicines from a reliable source. So using a local pharmacy, if you're buying something from the internet, make sure that internet pharmacy is well recognized. A lot of people buy these medicines thinking they're coming from Canada, but they're not coming from Canada. They're coming from all over the world. Anybody can be sitting in a basement anywhere on the planet and run an internet pharmacy. I'm not saying those medicines are bad, but they could be really bad. they may not have the medicine which it claims to contain, or worse, they might contain other ingredients which you don't need or you don't want in your body. So finding a local pharmacy and developing a relationship with the pharmacy, I would strongly recommend that. Also, keeping a list of your current medications on you. So some people don't, they know they take 5 medications or 10 medications, but they don't have the list of medications on them. So if you go to a pharmacy, they can easily print out a list of all your current medications. Also keeping a log of your med history. So sometimes doctors are changing a lot of medications. One is added, the dose is increased, dose is reduced, adding a medicine, deleting a medicine. So keeping a log can come in very handy if you're going through a challenging health condition. Supplements. So some people think natural products are safe. All the herbal supplements, they are much safer than the chemical medications. Not true. Because supplements, herbs, essential oils, all these products also contain a lot of different chemicals, and they will interact with your existing medicines. Now, how do they interact? We don't know much about it. We know about some of the herbs, but not about all of them. So I want you to be aware of that and maybe discuss that with your doctor or the pharmacist if you're using a lot of supplements, just making sure they're not interacting by potentiation or antagonizing your existing medicines. Also observe the effects on your body, particularly when you start taking a new medication. If you're taking a new medication, you notice a side effect, you want to discuss that with your provider, with your doctor or the pharmacist. So I see a hand raised. Julie, can you help us figure out how Tariq can ask me a question?
Sure. If you are on the phone, dial *1 and you'll be put through an audio queue, and our Ready Talk operator will put you through. Otherwise, you can type it in the chat box.
Thank you, Julie.
And at this time, I'm showing no questions or comments over the phone lines. Again, *1 to signal.
All right, we're going to keep going, and if anybody has questions, please put them in the chat box. That will be much easier, so we go through the presentation, and I can always come back to these slides if you have any questions. Okay, so next point is making a list of potential side effects or adverse drug reactions and reporting to your healthcare team. And consumers can also, you can also report adverse drug reactions to FDA directly. So when you report adverse drug reactions, it will help other people. It improves our database. That's how we learn about the medicines over a period of time, what is really not so good about them, so we can help other people as well. Sometimes doctors are too busy. They may not be able to do it, but please tell your doctor, can you put it in FDA's MedWatch program? And as a consumer, you can just call 1-800-FDA-1088, or you can go to the FDA website. I can send you the link later on, or you can just Google FDA MedWatch program and you can record your adverse drug reaction. So as we discussed in the beginning, polypharmacy is kind of a new science, and all the interactions happening are causing more complexities. People come to us, they're already taking 5, 10, 15 medications, new medications come in. So it's adding more complexity. So it's very important we contribute to this database as well. Okay, so strategy number 3 is called medication therapy management. So the Medicare system, the federal government really insisted on doing the MTM, medication therapy management. That started about 10, 12 years back. The concept is you can make an appointment with your pharmacist, sit down with them, and have them review all your medicines. What the pharmacist will ask you to do is bring everything you have at home, your big bag, all the boxes of medicines, herbal products, supplements, empty bottles. When I do MTM sessions for people, I find a lot of expired medicines or older medications which people aren't using anymore, but they keep them on hand thinking they might need it in future. So that can be sometimes dangerous. So it's a good idea to let the pharmacist review all that. So when I meet a person for MTM, I'll reconcile all the prescription medications and identifying if there's any medication error, if there's any safety issue, if there's any risk involved, if there's any side effect, what medicine is possibly causing that side effect. And we may make a recommendation for changing the medicine, reducing the dose. So we can call the doctor and work with the doctor. So working as a team, so the patient, the pharmacist, and the doctor, we work together so that the clinical outcomes are better than what we are getting today. Wonderful. So our chairperson here already posted a link for the MedWatch program. You can see that. De-prescription. So de-prescription is another new science which is emerging with the help of pharmacists. So in de-prescription, we identify what prescriptions can be safely reduced or eliminated over a period of time. Having said that, I'm going to put a disclaimer here. We're not asking to stop your medications or reduce your medications without discussing with your doctor and the pharmacist. So let's talk a little bit more about de-prescription. So de-prescription is planned and supervised process of reducing or eliminating any medication that might be causing harm, or it might be ineffective. Or it might be a medicine which a doctor started you on many years back and it may not be needed anymore. So we are still learning that more the better doesn't really apply for the medications in our healthcare system. With antibiotics, we learned we overprescribe antibiotics, so we have antibiotic stewardship programs. Painkillers, particularly with opioids. So we have opioid crisis now. Unfortunately, because of that, that alarm which went off, people who really have chronic pain, they are having a hard time accessing those pain medications. For healthcare providers, doing de-prescription might require a little bit more skill. So prescribers are trained to write prescriptions, which is much easier, but de-prescription will need a little bit more training. And for the patient, for you, it might require a little bit more effort. We'll talk about that in a few minutes. So it's an emerging science, and in this science, we are focusing on certain category of medications, like antipsychotics, benzodiazepines, which are anxiety medications usually, proton pump inhibitors. So PPIs are medicines which reduce the acid in the stomach, so like Prilosec, Nexium, pantoprazole, so these kind of medications. So I'll give you a very quick example here with PPIs. So if you experience heartburn, it's not a good sensation. You go to the doctor, or you can even buy these products over the counter now. When you start taking them, you'll be taking them probably for the rest of your life. Because if you withdraw it, if you stop the medication, it will cause the rebound acidity, which will make the problem worse. So we don't have the science for de-prescription of PPIs yet. So this is what we are working on. If you continue taking PPIs, those antacids, for a long time throughout your life, they are not only interacting with other medicines, they're also inhibiting the absorption of minerals, vitamins, and many, many nutrients. So we are finding as people grow older and they're taking their PPIs, their bone density may not be good, so they're leading to osteoporosis. They might have less vitamin D or B12 or those ingredients. You might be taking a multivitamin, but they're not being absorbed properly because there's not enough acid in the stomach. So this is where the role of the pharmacist comes in, determining what is the best candidate for eliminating the medication, which medicine will be good to start with, developing a safe dosage plan, how do we titrate, how do we taper these medicines slowly so you don't experience the withdrawals or the side effects of tapering. At the same time, you may want to integrate some non-pharmacological interventions. So I'm going to talk about that in a minute. And assessing your progress, is it a long-term option for you or is it just a short-term option? So strategy number 4, integrating non-pharmacological options. National Institute of Health, called NIH, recommends that we use some of the integrative health practices. They have a department called NCCIH, which stands for National Center for Complementary and Integrative Health. So what they are doing is they're doing a lot of research on complementary and integrative health practices to see how they can enhance our health. So they're doing research on natural products, all the herbs and supplements, but also on practices which are more holistic practices like therapeutic yoga, meditation, Tai Chi, acupuncture, massage. So those kind of modalities, if we start to integrate into our own life, we will be happier and healthier and hopefully reduce some of the prescription burden. These modalities also might help with managing the side effects of the medications. And certain conditions we have found, like anxiety, depression, insomnia, some kind of chronic pain and fatigue, those conditions are very easy to treat with these non-pharmacological interventions. So these are the areas that you want to probably target when you discuss with your healthcare team to assess which medications you want to reduce. And of course, you want to discuss everything with your healthcare team and also doing the research to identify the right experienced provider. So if you're going for a massage, you want to make sure that massage therapist is licensed. If you're going for yoga classes, you want to make sure that they understand your disease conditions, they understand your medicines a little bit, so they're not taking any risk with your health conditions or medicine by giving that kind of intervention. All right, I'm going to give you a couple of examples. So one of the case studies I had about insomnia, we are doing a clinical trial in state of New Hampshire for people who are experiencing cancer but also have insomnia. So this gentleman is in his 60s. He had stage 4 lung cancer. He was on 25 medications a day, and he also had chronic insomnia for about 14, 15 years. So when we gave him a yoga class, once a week intervention, after 4 weeks, he was sleeping so well, he discussed with his doctor, his trazodone was eliminated. After 8 weeks, his temazepam, which is a benzodiazepine, helps with sleep and anxiety, his dose was cut down to 15 milligrams for 30 milligrams. He was sleeping much better, and he observed that his ability to manage pain was also enhanced. His wife, when she saw the improvement for this gentleman, she also came to our yoga session, and she found that she was able to sleep much better just by doing the yoga capsules. So yoga capsules are short yoga practices which are very specifically targeted for a disease condition. Another case study is Parkinson's disease. So this lady had a lot of health conditions. She came with a walker. She had breast cancer originally. That was her main diagnosis. But she also had Parkinson's disease, diabetes, morbid obesity, knee replacement, arthritis, depression, had low thyroid hormone, and also had lower lymphedema, in which the legs swell up because of accumulation of the lymph. So she was coming to our classes on a, off and on for about 4 years. At that time, we were not collecting the data on these kind of outcomes, and it was really alarming when we saw her Parkinson's medication was reduced by 1/2. So that was very exciting because most people, when they start taking Parkinson's medications, over a period of time, the requirement of the medicine keeps increasing. And here we saw a reversal. She eliminated the need for the walker. She started to use a cane, which she was using very rarely. Postural stability improved, the movement improved, her depression eased, and she lost about 33 pounds of weight. And she was doing all this once a week intervention of seated therapeutic yoga. So nothing was on the mat. She was able to safely do the practice, and it made such a huge impact in her life. Pain management. So the Veterans Affairs has been integrating a lot of integrative health practices, those holistic practices, throughout the country now. They have a task force, nationwide task force, to include these practices. So they started with some of the hospital systems. So I was part of one of the hospital systems in the Manchester, New Hampshire, VA, where we were doing some education and integrating some of the holistic modalities. So I worked with their pharmacists, so we were educating people about their medicines and also gave them a yoga session. So I would spend about 2 hours per session and to see what were the outcomes like. So they published this data in 2011. 26% of the Army patients were prescribed at least one type of opioid medication. In 2 years, it was reduced to 24%. So you might think that 2% reduction is not huge, but it was very significant for the people who were using those opioids and their families. And also, it was just a start. So we are also creating a cultural shift while saving a lot of money, even by reducing it by 2%. So we know about the opioids now. It's such a crisis, a 2% reduction was huge. So now I've recently heard by 2020, they want to implement all these holistic modalities throughout the country now. So that's very exciting that we are not focusing just on pharmacological interventions, but we are integrating non-pharmacological interventions as well. So this was a study published a couple of months back, August 2017 actually, specifically for people who are dealing with spinal cord injuries and they also have neuropathic pain. So the study was done on 109 patients. Out of them, 79 people were taking 2 or more pain medications. Just by patient education about the medicines, what is good about the medicines, how does the medicine work, and what are the side effects of the medicine, just by education, they reduced that number of 79 patients to 36 patients. And this was done just with 6 educational sessions about the pain management. So that I find is very exciting, that it's not the pill which is working with neuropathic pain, but is the education which is also helping people. And they also found in the study the medicines which were being used, mostly they were gabapentin, pregabalin, which is also known as Lyrica, and amitriptyline, which is known as Elavil as well. These medications, they reduce the pain intensity only by 20 to 30%. And they had a lot of issues associated with polypharmacy cost and the side effects. So education helping with pain management is very exciting. So next strategy, strategy number 5, is aiming for health and resilience. So identifying what chronic conditions you have which can be prevented or can be reversed. So right now, unfortunately, we think we are getting old, our health condition is going to deteriorate, so we keep adding more medicines. But if you take a little proactive approach by changing your routine a little bit, adding food timing, the hydration that supports your health goals, that can be very powerful in avoiding, reversing, and preventing chronic conditions. So drinking enough water, eating healthy food, movements, even if they are small movements, that can be micro movements. So you can do them physically, or you can just visualize those movements. Socializing has huge impact. So you can do it in person or with the use of technology. Self-checking for the emotional and mental health. So we know that depression, anxiety, anger, or any strong emotion, we all deal with it as a normal reaction. But if it is too much for you, seeking professional advice. And last but not the least is the regular schedule for relaxation and sleep. In our culture in modern times, we do not really focus much on relaxation and sleep. So sleep, I'm not just talking about getting 8 or 9 hours of sleep a night. I'm talking about improving the quality of sleep. So there are a lot of techniques which can help us with both learning to relax and improving our quantity and quality of sleep. So aiming for all these things so that you're taking a little proactive approach for health instead of waiting for a disease to show up and then we have to jump into a crisis situation with pharmacological interventions. And the last strategy is keeping your hope up. There are a lot of people in your support team. You may not even know those people. And I love this quote from Christopher Reeve. He said, once you choose hope, anything is possible. Anything is possible. So just a quick summary. Know your pharmacist, know your medication, have your medications reviewed regularly by pharmacists. MTM sessions, many insurance companies actually cover those MTM sessions if you're taking 5 or more medications. So check with your insurance if you're eligible for medication therapy management. Research all the integrative health options, non-pharmacological. If you're taking any health supplements, put them in the category of your medicine so that pharmacists can check the interactions. Aim for health, hope, and resilience, and asking for professional advice. And engage with Reeve Foundation. Reeve Foundation provides a lot of tools for education, peer mentoring, so you can be a peer mentor or you can seek the help of a peer. There are a lot of research updates, social and emotional support, regular blogs and webinars with Nurse Linda, Dr. Dan. So please utilize all those resources for your own sake. So that's what I have to talk about. So thank you so much for your attention. And I'm open for questions. I have my website up here. And if you want to connect to Facebook, it's our page is called RxRelax. And I'm looking forward to your questions.
And once again, ladies and gentlemen, to signal for a question or comment via the phone line, please press *1 on your telephone keypad, or you may chat your question via the chat box as well. Again, *1 over the phone lines, or you may chat it via the chat box.
Thank you, Alan. So I got a question here in the chat box. Who will review the medications? So usually a pharmacist or the doctor, or I would say both, would review your medications. Nurses can also do that, but I think pharmacists are really well positioned here to review all your medications. We do that anyway, but if you're getting all your medications from different pharmacies, it becomes very challenging. Okay, I'm ready for the next question, or if you want to add more to your question. So the original question was to who will review your medications, and this is to check for the interactions. Interactions, yes, but also reviewing the medications, like whatever medicines you have at home, are they expired? Are they still good? What can be thrown away? There might be duplicates. For example, we talked about Tylenol or acetaminophen. Many medications contain the same medication, like Percocet is a combination of oxycodone with acetaminophen. So those kind of things a pharmacist can identify with your prescription medication, over-the-counter products, as well as supplements you're taking. Next question I have is, what do you consider inappropriate polypharmacy? Inappropriate polypharmacy is when you are taking a medication which is not required or is causing too many side effects. So yes, there could be very appropriate polypharmacy where you have multiple health conditions, you're taking multiple medications, but when you get into the trap of the cascade, where you're taking more medications to reduce the side effect of the original medication, that's when it becomes very inappropriate. I have a hand raised, so you're welcome to unmute yourself, Diane, and ask the question, or you can use the chat box.
Alan, do we have any questions on the phone?
No, ma'am. No questions or comments at this time. Again, *1 to signal for a question or comment over the phone line. And I'm showing no questions or comments over the phone lines at this time.
Thank you, Alan, but I see one in chat box. So the question I have here is, can diazepam versus Ambien to support sleep? So diazepam can cause memory issues. I have a prescription for Lyrica too, but been afraid to take it. Could this be used to sleep instead of the other two? What am I missing here? So I was thinking of, like, with the scope of this presentation, I'm just giving an overview of what polypharmacy is, how it can impact you positively and adversely, and how can we manage the adverse effects of this situation. So I'm afraid I cannot give you a very specific answer. In my opinion, every medicine is perfectly all right to take if it is recommended for you, and every medicine also has a lot of issues. So unless I have your full medication history, and I say like, oh, this medicine is better than the other one, I'm taking little chances. Having said that, I would say for sleep, there's so many integrative health modalities, there's so many sleep hygiene techniques you can utilize, which will actually work, which will be much safer than any of these medicines and will work more powerfully. So they're recommended as first-line treatment nowadays. So all the sleep medicines we have, they're not first line. Even a good doctor would recommend the first line is cognitive behavioral therapy. All the, what do you call them, do-it-yourself practices. So what you can do yourself to improve your sleep and what you can do with non-pharmacological interventions for sleep are much more powerful. And there are a lot of sleep hygiene techniques which you can study upon those as well. And you're welcome to send me a message. You can email me or call me. I don't know what the system here with Reeve Foundation is, but if I receive more questions, I would love to answer those questions as well. Particularly with sleep, I really love coaching people about insomnia and how can people sleep better, because once the sleep is better, a lot of other health conditions can be improved as well. Next question I have is, how do I know when the side effects are worse than the benefit of the medications? Excellent question. So risk-benefit analysis, that's what you need to do with your team of health professionals. So with your doctor and the pharmacist, discussing this very question can make a lot of difference. So sometimes it's very easy if doctor is very busy, they're just writing prescriptions, pharmacist is very busy, they're filling prescriptions, you get all these medications. At that time you need to raise this question, what is the risk, what is the benefit, and let's analyze, go from there. So right now in the healthcare industry, we are talking about person-centered care, a human-centered care. So what is your own assessment? What do you think is right for you? So as a healthcare provider, it's very easy for me to say, hey, this medicine is going to work really good for you. But what does your body talk about? How is your body responding to it? So that human-centered design is, we are still talking about it. It's not really, unfortunately, being implemented, but this is the direction we are going into as we start to provide more value-based care instead of fee-for-service model. The next question I have here is neuropathic pain. Education alone decreased the need for pain medication. So that was part of the study, yes. I'm on currently 2 anti-seizure medications, and the pain breaks through every couple of months, and they keep adding or upping my doses. I didn't take any medications before, and I prefer not to now. So again, good point here. And when there is a breakthrough pain, sometimes, yes, doctors don't want you to suffer through the pain. They will add the medicine. But having that kind of discussion, having that intelligent discussion with a provider before they write a prescription, I think is a very, this is what we are encouraging you to do here in this presentation. So the next question or comment I have is, I have a CPAP machine now, have great sleep hygiene, I swim, I do yoga, but need pill to sleep. Okay. So many of the sleep medications out there in the market, they are habit forming. So the most common medication which is being prescribed to people is Zolpidem. The brand name for Zolpidem is Ambien. Unfortunately, because they are habit forming, people lose their natural sleep cycles. So I love talking about sleep, so I can talk for another hour, so I'm not going to keep you here for an hour. But just to give you a synopsis, sleep is not just turn on the switch and turn off the switch. Sleep has huge architecture. There are various stages of sleep, and those stages of the sleep, they repeat. So we go into different sleep cycles throughout the night. By taking the pills, we might feel sleepy, we might fall asleep, we might stay in the sleep for a longer time. But sleep architecture, if that gets disturbed, you will not wake up rejuvenated in the morning. So maybe we can have more offline discussion on the sleep some other time. But yes, there are a lot of techniques out there. Yoga, for example, you mentioned here. So yoga is very elaborate, like comprehensive practices out there in yoga. And some of the practices I use in yoga when I teach to rejuvenate people. There are practices which can make you sweat a lot. There are practices which can boost your metabolism. They will energize you. They will keep you away from sleep. Then there are practices which can make you so relaxed, which will help you with sleep as well. The next question I have is, I have been through psychotherapy also, so I'm assuming this was for sleep, but I missed that part here. You're welcome. And what type of physicians will do a benefit analysis with you and pharmacists? Great question here. What types of physicians will do a risk-benefit analysis with you and the pharmacist? So every physician is supposed to do that. This is their, as a health provider, this is our main job. When somebody is sick, we are correctly diagnosing what the problem is. What is the symptom and what is causing the problem? So dissecting that problem into two parts, what is the diagnosis and what is the symptom of the problem? And a good provider will attack both of them. So let me give you an example here. If somebody has fever, a doctor will not only write a prescription for fever-reducing medication like a Tylenol or ibuprofen, they will also give an antibiotic, right? So if you have an antibiotic which is attacking the root cause of the problem, which is the infection, and also helping with the symptom of pain or fever or fatigue, that's a good provider here. Unfortunately, for chronic conditions, it may not happen always. With chronic conditions, sometimes we try to manage the symptoms of the problem instead of fixing the root cause. So this is where I feel like we need to be empowered patients. So if I feel empowered, I have good questions, this is what you will discuss with your physician, and you will also discuss with your pharmacist once you get the prescription. Say, okay, hello pharmacist, tell me, this is my issue. Is there more risk or the benefit? And then you will evaluate how your body responds to those medications and do your risk-benefit analysis. So working as a team together. I have a comment here. I have been through psychotherapy also, but I don't have a question related to that. So any other questions before we close today's seminar?
And I'm showing no questions or comments over the phone line.
So Julie, shall we close for the day?
Yes, thank you.
Thank you so much for everybody being attentive, and thank you Reeve Foundation for providing all the resources to the community as well.
Yes, I want to thank you too, Jay, and I want to let everybody know that this is being recorded and it will be hosted on our YouTube channel by the end of the week. So thank you so much for your time today.
Thank you. Take care.
All right, bye-bye.